Thank you very much. Thank you, Dr. Infante, for the kind invitation. So let's move on to the next session, which should be a very interesting one regarding diagnostics of suspicious findings. As we are already late, I would already give the word to Dr. Tauli, who should give us a talk on MRI evaluation nodules.
Thank you. Good afternoon, everybody. I'd like to thank Claudia Henschke and David Yakelovitz for inviting me here. I'm a little bit an outlier because I do imaging below the diaphragm, but I'm interested to talk a little bit about what's happening also above. So thank you. Can I have my slides, please? Okay, so I was asked to talk a little bit about magnetic resonance imaging for lung nodules. Next, please. Oh, here, thank you. This is my disclosure. Moving. Okay. All right, so first question is, why do we use MRI of the thorax or of the chest? Here at Mount Sinai, actually, where I work, we do MRI for certain indications. Most prominent one is mediastinal mass characterization. We feel it's sometimes easier with MRI, and this is an example. Do you have a pointer? System, yeah. So this is an example of a large thymoma. You can easily characterize the cystic nature of these masses or their solid components. Some people also use MRI of the thorax for a whole body MRI in oncologic workup. Makes it really easier. For example, if you have a rectal cancer patient, when you can whole body imaging and look at the same time for metastatic staging, lung cancer staging, lung cancer screening, I'll show you some data, and also MR angiography and MR venography for PE, for example, in patients who are allergic to iodine, to look for thoracic aortic aneurysms, pulmonary hypertension, etc. So there are many advantages to MRI compared to CT. Of course, the most important one is its non-ionizing technology. So it's based on, magnetic resonance imaging of H1, basically of the protons in the body with radio frequency acquisition. It has a higher contrast resolution, sorry, not spatial resolution, but lower spatial resolution compared to CT. You can use gadolinium-based contrasting agents, GBCAs, which really gives you a lot of information about enhancement, perfusion. You can use subtraction to characterize tumors better. You can look at blood flow and perfusion with MR angiography, but also with 4D flow imaging. And there's also other applications like ventilation, using helium, hyperpolarized gas, respiratory motion, etc. So this is just an example of whole body MR using whole body diffusion or DWIPS. This is using inverted high diffusion, high B-value diffusion, and you can really do a whole body acquisition from pretty much from head to toe. We've been using this, for example, for multiple myeloma cases, but also for prostate cancer. This could be combined with PET imaging to do when we use PET MRI. So it really maximizes the information about, bone metastases, lymph node metastases, and potentially for lung nodule characterization. There are, of course, many limitations to MRI because of the low proton density and fast signal decay in the lungs. There will be less sensitivity to smaller lung nodules. It's going to be harder to see. There'll be more artifacts because it's slightly longer to acquire. There's some respiratory, vascular, and cardiac motion artifacts you need to deal with. And of course, the access is the problem because it's very hard to get access in certain areas or certain countries. The cost is more expensive than CT, and there are also contraindications, especially in the older patient population, including, pacemakers, etc. And the length of exam is typically at least 10 to 20 minutes if you do an abbreviated MRI. So protocol, very briefly, it's basically 1.5 or 3 Tesla. We like to use breath hold 3D GRE sequences like LAVA or VIBE, pre and post contrast with subtraction. T2 weighted imaging is important as well. Diffusion helps with tumor detection, and there's some other sequences specialized depending on the indication. So for lung nodule detection, there is already some data from the early 2000s that showed reasonable sensitivity for detection of lung nodules using MRI, usually using either T2 weighted imaging, such as STIR or T2 FSE or T2 HASTE. And you can see the sensitivity was 100% for lesions over 1 cm. The problem is for lesions below 3 millimeters, as you can see, sensitivity is much lower, which is probably a thing sometimes. There's this paper also, important study in 10,000 healthy individuals where they looked, it's not really a screening study, it's more about a detection study. And they looked at 10,000 individuals using whole body MRI exams in 11,000 subjects at 1.5, 10-minute exam. And they found that about 5% of the population had suspicious lung nodules, and about 49 of those were primary lung cancers detected with this whole body MRI study. This is an important study that just came out actually this year. This is a multi-center German study where they basically compared MRI prospectively to low-dose CT for accidental lung nodule detection in patients with COPD. They enrolled about over 560 patients, and patients had the same-day MRI with contrast without UTE, which I will discuss in a second, and low-dose CT. And they found very reasonable sensitivity for MRI. However, it was lower for smaller nodules, as you can see, about 60% for solid nodules, only 17% for part solid nodules, and less than 10% for ground glass opacity nodules. But when the lesions were detected, the lung rads with MRI was equivalent to that of CT. So the conclusion of this study published this year was that MRI was not as sensitive as CT for small nodules, but it was equivalent for characterization. And I just want to finish, because of the interest of time, I want to talk about UTE MRI, which is probably the future of MRI. UTE stands for ultra short TE MRI. So the TE is echo time, is the way to recover signal on a sequence. Typically, the TE can be long, thus the signal recovered from the lung is going to be lower. But if you shorten the TE with what we call UTE, signal is going to be maximized, and eventually you can get images that look like CT. And I'll show you some images in a second. This could be used either 3D volumetric radial acquisition, for example. You need to do some gating to compensate for breathing. And this is an example from our own experience from Mount Sinai. This was done during the COVID pandemic. You can see really no major differences in image quality between the MRI on the left and the CT. This is reformatted using UTE. And you can see very nicely ground glass opacities also with MRI compared to CT. And the data with UTE MRI is very promising, actually much better than standard MRI sequences. For example, a recent study from 2017 showed that the 3T, meaning high field UTE sequence, had similar sensitivity and specificity to CT in non-screening population. And you can also classify lung nodules with UTE as solid, subsolid. The only problem is that it does underestimate nodule size by 1 to 2 millimeters compared to CT. And this is a recent study also from Germany, 2022, that showed agreement between UTE and low-dose CT and standard-dose CT, almost perfect for lung nodule characterization in about 1,000 nodules in 200 patients. Okay, I think I'm going to finish here because I'm already over my time. So I think we know that, of course, CT is the gold standard for lung nodule or lung cancer screening, but MRI may play a role in a certain subpopulation of patients who need repeated studies. For example, patients with COPD, younger, etc. And I think overall now what is promising on the horizon is really the use of this UTE technology that can recover a lot of signal to detect even smaller nodules compared to CT. And it may be easier actually to evaluate because nodules stand out against the signal-free normal lung with this technology, and it may be actually less sensitive to non-important nodules that are below a certain size, but that has to be demonstrated by more cost-effectiveness data compared to CT. Thank you.
Thank you, Dr. Tauli. We'll ask Dr. Infante at the end of the session if there's time for a question. I would move on to the next speaker, who is Dr. Cham, who will discuss when a biopsy is unnecessary. Please, Dr. Cham.
Waiting for my slides. Thank you so much for the opportunity to be here today. Great. No disclosures. Indeterminate lung nodules and suspicious lung nodules are commonly encountered in the setting of lung cancer screening. And these often will lead to a lung biopsy, as you can see here. And if the biopsy results are positive, they'll often end up in surgical resection, regardless of whether it's true or false positive, which you won't know until after the surgery. And if it's a negative result, patient usually will continue on to surveillance, watchful waiting, as they say. In the context of lung cancer screening, surgical resection is indicated for biopsy-proven early-stage cancers. And the reason this system works is because of the very high positive predictive value of lung biopsies, which is greater than 99%. And this has been shown by multiple studies across the decade. So the question is, if lung biopsies have a positive predictive value of greater than 99%, then biopsies technically would be unnecessary if imaging features could also achieve a greater than 99% positive predictive value. So the question we now have to ask is, what patient and imaging characteristics would result in a greater than 99% probability of lung cancer in the absence of a biopsy? So we then move on to Dr. Google, who recommends these lung cancer risk calculators. And the first one is published in the website UpToDate. It's called the Brock calculator. And here you can see that the calculator asks for the patient's age, sex, family history of lung cancer, emphysema, nodule size, nodule type, location of the nodule, how many nodules there are, and whether it's spiculated. And it's a very complex formula, as you can see here. This is the equation that is used to calculate this chance of malignancy. And what you'll notice here is that even when we fill out all the most dangerous or potentially cancer risk factors, including age of 99 years, female sex, positive family history of lung cancer, positive emphysema, nodule size of 30 millimeter, which is technically a mass, with a partially solid consistency, which is another higher risk factor for malignancy, nodule in the upper lung, nodule count of 1, and speculation. Still, the cancer probability, as you can see at the very bottom, is only 94.9%. Doesn't quite reach the 99% cancer probability from a lung biopsy. And if you remove many of these parameters, the cancer probability drops down to 62%. Now, if we change the age to something more reasonably encountered in a setting of a lung cancer screening, such as age 80, you'll see that the probability is around 91%, keeping all the other parameters maximized. And if we drop that age down to 70, the probability drops to 89%. And if we change the nodule size to something smaller, 20 millimeter, the cancer probability is now 80%. So what about growth rate? You'll notice that this formula doesn't take growth rate into account, which is a very important factor when we're talking about lung cancer screening. So for that, we go back to Dr. Google and we look at the other calculators that are online. So the second most utilized one is from the Society of Thoracic Surgeons. They include number one, the Brock calculator, which we've already talked about. And the second one is the Bayesian inference malignancy calculator, which I just learned from this morning was actually developed here in Verona, just by coincidence. If we then enter the estimated prevalence of disease in the referred population, which is 2%, about 2% of the patients undergoing screening will end up with lung cancer. The special feature of this calculator is that it now includes volume doubling time, which I've highlighted here. So now if we, again, maximize all the parameters and include a volume doubling time that matches that of cancer, but keep the edge as smooth, you'll notice that the probability of malignancy is only 87%. Again, doesn't quite reach the 99% chance of cancer that we'd get from a lung biopsy. I can see the margins of the lesion is very important in determining whether it has a high probability. So if we change the FDG PET to now FDG AVID with an SUV greater than 2.5, you'll see that the probability of malignancy is still only 91%. Again, because the edge of the nodule is smooth as opposed to spiculated. Finally, the one remaining parameter that we haven't maximized, which is the edge detail. If we now specify that it's spiculated, the probability of malignancy is now 99%, even if the patient has a PET avidity status that's not known or PET was not performed. If we change size now, instead of 3 centimeter, we change it to 4 to 10 millimeter, the probability goes down to 97%. If we change it to a slightly larger size, 11 to 15, we again reach a malignancy probability of 99%. And this time, if we remove the FDG AVID status to not known, the probability of malignancy goes down to 98%. And finally, if we increase the size to 16 to 20, but keep the PET status as not known, we're able to maintain a probability of malignancy of 99%. So in summary, in the baseline screening round, where you don't have any information on growth rate, imaging alone may never achieve a positive predictive value of 99%. That's based on these calculators. And in the absence of speculation, even on the subsequent rounds of screening, on the annual repeats, a positive predictive value of 99% cannot really be achieved by imaging alone. Again, in the absence of speculation, even if the nodule had the same growth rate as a cancer or matched the growth rate of a typical cancer. When speculation is present, the following is necessary to achieve a positive predictive value of greater than 99%. The nodule has to be at least 16 millimeter in size, or it has to be at least 11 millimeter and FDG AVID. I also want to point out that the sensitivity of FDG PET for cancers less than 10 millimeter is only about 50%, and so that second situation may not be very easily encountered. Future considerations, the positive predictive value of a lung biopsy result is greater than 99%. However, it's questionable whether this is an unnecessarily high standard. That is, if the positive predictive value were only 90% or 80 or 70, would that be clinically adequate for lung cancer screening? In other words, would it be acceptable if 10% of surgeries revealed a benign nodule in the setting of lung cancer screening, considering that these patients are asymptomatic? We may also consider that this may have to be personalized via shared decision-making. Some patients may be okay with 10%, whereas some patients may prefer to have a 0% chance of a benign diagnosis after surgery. So with that, I'd like to thank you for your attention.
Thank you, Mr. Cham, for this very interesting talk. And let's move on now to the next speakers, who are Dr. Pupini and Lando, who will discuss about cone-beam CT guided lung biopsy. Lando.
Thank you for the presentation. So here we are. When I came to the preparation of these slides, I actually thought what various specialists would like to hear from me. So the first picture I show you is how an angio suite looks like in reality. So there's the bed where the patient can lay during the procedure of the biopsy, laying on the prone or supine or lateral decupitous position. There's the angiographic machine with the cone-beam CT integrating into it. There's the pump to inject contrast medium as required from the operator. There's a monitor to a multi-parameter monitor to follow up the vital signs of the patient. But what's so special in cone-beam CT? Cone-beam CT is based on a gantry which has a C-shape. On the extremity of this gantry, there are mounted an X-ray beam generator, and on the other side, a flat single detector, which is able to generate a volumetric image by a single rotation of the arch around a section of interest of the patient. This cone-beam CT, this computed tomography, is small and therefore is able to fit into an angiographic suit. In the pictures, so the image acquired from the Combin CT is something like the one you can see on the slide. The Combin CT is integrated with the software that allows us to draw a virtual needle that by simply pointing the entry point and the target point, and this virtual needle has a centimetric precision. The virtual needle is therefore then transferred into the fluoroscopy screen that we are able to see during the procedure, and this allows us to position the biopsy needle with the extreme precision and in real-time visualization we're doing. So from all these informations that are very, very quick for the time I have for the presentation, we have to keep in mind that what we would like from the patient is that he doesn't have to move throughout the entire procedure. He doesn't have to cough because every single movement of the patient starting from the first scan will raise the risk of non-targeting biopsy. The patients also have to be able to hold their breath as long as for the time of the rotation of the artery around the patient to have this volumetric image acquired. So at least for 10-50 seconds, the patients should be able to hold their breath. So in literature, there's an unanimous consensus about the superiority of the coaxial technique, which is based on the use of introducing needles, which are shortened than our core biopsy needles. The first introducing needles is so positioned to cross pleural just once, and it allows us to avoid multiple repositioning of the core biopsy needle, so reducing the risk of pneumothorax. So what should we expect from a patient that comes back to our department after having received a biopsy of the lung? The first and the most common complication is pneumothorax. It has variable incidence, but what is important at it is that really the most of the times is significant, clinically speaking. So it doesn't require a prolongation of the stay of the patients in the hospital and doesn't require thoracic drainage. Pneumothorax, such as hemorrhage after the procedure, can be monitored with chest X-ray. Usually, we suggest that the patient receive a chest X-ray after 3 hours after the procedure. The second more common complication is hemorrhage. It can show as simply pleural or parenchymal effusion. It can show as hemoptysis that usually resolves when the patient sits. And it can show with severe hemoptysis or severe hemothorax. In this case, we can easily go through the arteries of the patient and embolize the target vessels. Here, there are some less common complications, but what we have to keep in mind is that morbidity is higher, even though clinically less significant. The mortality is very, very low. What are the risk factors for these complications? So the position of the nodule, the morphology of the nodule, the needle path, poor cooperation of the patients, such as coughing, moving, not able to keep the position required from the operator, are all risk factors for the complications and also for the failure of the procedure. Here in this slide, I would like to show you a comparison between some references I found in the literature with a study we conducted in the last 3 years. These are a retrospective study based on pretty much 300 biopsies. We have found that collecting at least 3 samples for each procedure, thanks to this coaxial technique, allows us to have more diagnostic samples, so more diagnostic procedures. The same happens when the lesion is bigger than 20 millimeters. And I would like to point out on the 5th row where we can find that pneumothorax is not influenced by the number of samples because we use this coaxial technique with the introducing needle. as a radiologist at the end, I would like to point out the importance of the use of PET-CT combined with combing CT images in a fusion technique. This allows to find out where the most metabolically active parts of a mass are, so to target this part, or in the setting of multiple nodules, to target the most metabolically active nodule. So to conclude, C-arm combined CT percutaneous transneedle biopsy is an accurate and safe technique to determine the histologic nature of lung nodules. First, pneumothorax, and second, hemorrhagic effusion are the most common complications, though often being of limited import. And moving the mini-invasive procedures to the angiographic suite empowers the yield of multi-slide CT for diagnostic purposes. Thank you.
Thank you, Dr. Lando, for your kind presentation. And let's close the session with Professor Stefano Gasparini, who will give us a talk on the bronchoscopic evaluation of nodules.
Okay, thank you very much, Rocco. Can you see my slides?
We do.
Okay. First of all, I would like to thank Dr. Infante for this kind invitation. Of course, I will focus my talk on the role of bronchoscopy in peripheral lung nodule, because this is the topic of the Congress. Well, this is my conflict of interest disclosure. What do we know about the transbronchial approach to peripheral pulmonary lesion? The first thing is that the lower incidence of complications, especially pneumothorax, in comparison to percutaneous biopsy, would make it desirable that the transbronchial approach be considered as first step in the diagnosis of pulmonary nodule. And the second thing is that for the transbronchial approach to peripheral pulmonary nodules, a guidance system is required because there is a very low sensitivity of blind samples or of bronchoalveolar lavage. Fluoroscopy has been utilized for many years, and it is still the most used guidance system worldwide. But fluoroscopy has limits. The first one is that poor vision of small and or low density lesions, and poor vision of lesion hidden by mediastinal structures. And as you can see here, while the sensitivity for lesion greater than 2 centimeters is not so bad, for lesion less than 2 centimeters, the sensitivity is low and not satisfactory. This is the reason why in the last decades, a lot of guidance systems have been developed to improve the sensitivity and the diagnostic yield of the transbronchial approach to peripheral pulmonary lesion. Virtual bronchoscopy, radial Hibus mini probe that can be pushed in the periphery of the airway and can distinguish by ultrasound the nodule from the lung parenchyma, electromagnetic navigation system, and also in the transbronchial approach, combing CT in the last years has been used. The last innovation is robotic bronchoscopy and lung vision, that is an artificial intelligence algorithm that allows to mix, to share the CT image with the fluoroscopy, allowing the real-time sampling of the lesion. Well, I will not describe, of course, all the methods because of time, but I try to evaluate the cost of such systems. What is low cost and what is high cost? Because cost effectiveness is very important in this topic. I try to approximate the cost of the system, the cost of the disposable material per procedures, and the cost per procedure, considering the depreciation of the instrumentation and considering a center where 100 procedures per year have been done. And you can see here, there are systems that are quite cheap, and systems that are very expensive, like robotic bronchoscopy. And if we put together some guidance system, we are used, for instance, to use fluoroscopy with radial IBUS to confirm the lesion, and now with the lung vision. We are still under 1,000 euros per procedure. That is still a low cost in our opinion. While if we put together Combin CT, for instance, and electromagnetic navigation or robotic bronchoscopy and Combin CT, the cost is very, very high, 5,200 euros. And what about the sensitivity of these procedures? Sorry. The sensitivity of these procedures. As you can see here, the sensitivity increase in the high cost procedure. You can see that with robotic bronchoscopy, we can arrive at more than 90% of sensitivity. And with Combin CT also, we can arrive at more than 80% of sensitivity. These in white are the mean values. But there is no such huge difference between low cost, like lung vision sensitivity, and robotic bronchoscopy or Combin CT sensitivity. So the question, the problem is that there is also an heterogeneity of results, and this is because different studies are not comparable, because there are many variables that come into play in this setting: the size of the lesion, the location, the presence of bronchus sign, the sampling instruments used and the number of sampling. The operator skill is very important in bronchoscopy. The use of ROSE, yes or no. The use of ultra-thin bronchoscopes that could improve the sensitivity of the transbronchial approach to peripheral lesion, the prevalence of malignancy, and if the authors use more than one sampling instruments or more than one guidance system together. In effect, most of the studies use guidance system associations, as you can see here: electromagnetic navigation, Combin CT, radial IBUS, or robotic bronchoscopy, Combin CT, or radial IBUS. So it's really difficult to really evaluate if the expense of high-cost system is justified. What is the response to these questions? I would like to reply with sentences of one of my favorite singers, that is Bob Dylan. The answer, my friend, is blowing in the wind. The answer is blowing in the wind. Because there are no prospective randomized studies on large series that compare the different guidance system in terms of diagnostic yield, safety, and cost effectiveness. And we wrote this editorial together with Ales Rodzman from Slovenia, Respiration in 2002, Dancing in the Dark. And we underlined that there are no comparative studies between different navigational methods. And also, there are no studies between biopsy accessories that could be used during the transbronchial approach to peripheral lesion. Furthermore, there is this recent study from Gerard Silvestri that is impressed on chest. That is impressive because a lot of lesions were analyzed, more than 16,000 lesions, and the authors found no significant difference in yield when comparing different technologies and when comparing study performed before 2012 and after 2012. So The diagnostic yield of guided bronchoscopy, according to this study, has not improved despite the reported advances in bronchoscopy technology. So in conclusion, the future of bronchoscopy for the transbronchial approach to peripheral pulmonary lesion is, of course, the advent of new technologies, and it seems that robotic bronchoscopy may help in this field. But we need also prospective randomized study that compare the different guidance system and that compare the transbronchial versus the percutaneous approach in terms of safety and of diagnostic yield. Furthermore, we need also the rationalization of resources, and of course, and this is maybe a job of the scientific society, the identification of centers with high volume activity where to concentrate expensive technologies. Thank you very much for your attention.
Thank you, Stefano, and to all the other speakers of this very nice session for your talks. And I will hand over the mic to yourself and Dr. Shaham, who will be chairing the next session on interesting cases and polling in diagnostics. Thank you.
Thank you, Rocco. Bye.